3:07 in the morning, that magical hour where everyone in the emergency department, including me, wishes they were asleep. A 32-year-old guy bursts through the doors, pacing, sweating, and convinced he's actively dying. He keeps grabbing his right flank. He's bent over, then standing, then pacing again. He can't get comfortable. He tries to lie down. Nope. He tries the bathroom. Also nope. He tries Googling symptoms. Catastrophic. We get his test back and surprise, but also not surprise, his CT shows a tiny, jagged little villain. A 4-millimeter kidney stone. A rock, the size of a lentil, bringing a grown adult to their knees. So today, we're talking kidney stones. Why they happen, why they hurt so much, and how you can stop your body from starting its own gravel business. This is Not Another Medical Podcast.
I'm Josh Levitz, an internal medicine physician.
I'm James Jung, a general surgeon.
And I'm Brodie Nolan, an emergency doctor. And this is Not Another Medical Podcast. The views and opinions expressed in this podcast are those of the host and guests, do not reflect the official policies or positions of any affiliated institutions or organizations. This podcast is for informational, educational, and entertainment purposes only, and it is not intended to provide medical advice, diagnosis, or treatment. Listeners should consult their own healthcare professionals for any medical concerns.
Brodie, did you just say shebang? Did you just say shebang?
It's like the worst way to start.
Yeah, listeners, as we were getting into this, Brodie just said shebang, time to go. And I may sign
off the record, the non-recorded shebang, which was supposed to stay that way. Dicks.
We had to uncover that. Uncover that dirt.
No, nothing is off the record.
My
here.
episode, my editing. This will be shebangless, guys.
That is true.
That's cool.
Man.
Oh man.
Yeah.
Josh,
what's up, guys?
You seem to be in a different place than your usual recording spot. Tell us.
Yeah.
I am. There's a brick wall behind me. After 5 years of talking about it, we have finally redone our front room, which is now our office, and it's wonderful. This room, when we moved into this house, was like 40 years old. There was absolutely asbestos everywhere. And we initially made the mistake of putting a spin bike in here. And after 3 minutes of biking, I couldn't breathe. And like my cardio is not great, but it's better than 3 minutes of biking. So we didn't go in the room again. And we finally just redid it over the last 6 months. And here we are. We have an office.
Oh, great.
Nice.
And the asbestos still staying or?
Yeah, that was too expensive to get rid of. So
Black mold is all gone. Lungs are better.
Yeah, we'll see. We're
gonna
start coughing. Just go with it.
I was going to say, well, watch your breathing as the podcast goes on.
That's right.
You start huffing by the end of it. We have some questions for your contractors.
Pulse socks on your finger. It's a live stream, pulse socks.
I've made a lot of bad life decisions. But yeah, no, it's pretty awesome. It's nice to do this. I used to just kind of hang out in my kitchen and everyone would walk by and I'd be like, it's time.
Yeah.
Hey, what's wrong with that?
A little bit of private.
Nothing. Yeah, it's true.
A little bit of privacy, I guess.
Yeah. Brodie, you're in your living room. You're not the kitchen.
Okay, I'm kitchen adjacent.
Kitchen adjacent. Yeah, you are.
It's not
in Toronto world. Yeah, exactly.
And you know what, guys? I was really excited to podcast in here, but I thought James was gonna just one-up me right away, saying he's going to Fiji to meet the prime minister of some but he didn't. So thank you, James. I appreciate you.
Well, I did just come from London, but I'm not gonna.
There we go. There we go.
I mean, I mean, since you asked, we did go to.
You really did ask, Josh.
I know that's on me.
Yeah.
Speaking of old bricks, I'm sure you saw lots in London.
Yeah, that's right. Speaking of asbestos and difficulty breathing.
Yeah, really.
Yeah,
how was it?
Oh. Actually, Broads, the last time I was in London was with you when we were backpacking through Europe. We had
literally with just backpacks.
Just literally just one backpack each.
Before carry-on only was a thing.
Yeah, and so it's been a while since I've been to London, and God, it was great. Just me and my wife.
Yeah, awesome, man. Team, today we're talking about something that does not need a segue. because
Ooh.
it is just so common and so painful that we just got to get into this.
Yeah,
I think
it had to be done. It's like ripping a Band-Aid off. I feel like
yeah.
yeah.
It's like peeing out. It's like peeing out a stone.
Yeah,
You
and
just gotta do it.
I'm gonna say it once and then hopefully never again. But I just have to get the whole childbirth analogy out of here, recognizing that there's 3 dudes on this podcast.
Yeah.
Oh boy, I apologize.
And often
to
we
everyone
hear
listening.
it's like giving birth or as painful as giving birth. I don't want to dive into that. I don't want to talk about it. I just want to acknowledge it and allow us to move on. Because I don't know. It just seems to be a thing that guys say, and I want the 3 of us to not be those guys.
Yeah, I agree.
Good call.
We
Good
know
call.
nothing
Thank you for
about
not saying
childbirth.
it.
Exactly.
No. So talking about kidney stones, that's what we're getting into. And Brodie, this is a fun one.
Right?
Why kidney stones? What kind of piqued your interest in this one?
I mean, besides the fact that literally my last 4 emerge shifts, I have had at least 3 people each shift that I have worked up for or have diagnosed kidney stones in. But you just get to the point of 1, you feel really bad. 2, I have this conversation multiple times on a shift about managing and pain control and what they are. I just thought it'd be kind of fun to dive in and be able to spend a whole episode on it. So that was kind of it, really. Just it's common. They're out there. But
it's
there's
going to be really
a lot to be
common,
learned.
right? Yeah.
Super common. Daily presentations.
I did a little bit of digging in the U.S. and Canada. It's about 10% of adults who experience kidney stone at least once in their life. That's a lot, right?
Is that
that is a lot.
adults by age or by maturity?
I don't think the kidney stones discriminate.
We'll get into risk factors, but I don't think
maturity is not a risk
maturity is
factor.
one of those.
Yeah, just checking.
Yeah, but even more so, right?
You're still at risk.
Yeah, you're still at risk. For Brodie in emergency rooms, I'm sure a lot of patients come in thinking that it's kidney stone, even though it's not a kidney stone, right? So I think you'll probably see more people, more than 10%, saying that they think that they have kidney stone, and you're working them up for it.
I like the common theme of things that present like something but really aren't that thing. And that's come up in a lot of our episodes. And this is another thing.
Yeah. The other thing, though, is I think that everyone that works in the emerge gets really good at spotting who does have a kidney stone. Because they often are the people walking around, can't get comfortable. They're heaved over, vomiting, look super unwell, and then they get a shot of Toradol, and all of a sudden they can breathe and relax again. But it's you can pick them out as soon as they walk into triage. You're like, that one's got a stone. And I feel so sorry for you.
Right? Yeah. I was going to ask, Brodie, since we're talking about kidneys, tell us a little bit, high level, what do kidneys do? And then we'll kind of start from there.
Yeah. And I'd like to say that kidneys are one of the most misunderstood organs. And I don't mean that from other people. I mean that from me. I hate kidneys. I hate learning about them. I hate about all the different electrolytes. Which salts go which way.
You got to spit down the urine.
Right?
I don't understand.
All of it sounds awful. So with that bias, kidneys are they're filters for your blood, right? So they help you get rid of waste. They help you balance the fluids in your bodies. You're not too dehydrated, but you're also not keeping, fluid on your lungs or in your legs. They're really important. You see people that are on dialysis, for example, right? Where their kidneys aren't working. These are things that people have to do either every day or every other day, depending on the type of dialysis they do. So they play a really critical role in keeping everything clean and balanced. But in the same way that if you're filtering things out or you're using your Brita or your water filter, over time there gets deposits and things, salts will be there, things will start to crystallize. It's kind of the same idea with kidney stones then, right? Fluids going through, things are getting collected like they should be, and then sometimes things can kind of precipitate and crystallize.
And I would say kidneys also give me a job because I feel like 90% of my patients come in with kidney injury. And so thank you, kidneys. Appreciate you.
One thing I would add as someone who studies anatomy, so Brodie said it's like a filter. So kidneys, there are 2 of them, left and right kidney. And then there's blood vessels that go in, so carry the blood and then carry the blood out of the filter. And then what's filtered out goes into ureter, which is the pipeline that connects the kidneys to the bladder. And then that's where the urine accumulates, bladder. And then When it's ready to empty, it will squeeze into the urethra, and then that's how you pee it out.
Yeah, that's great.
James, thanks for not going into the anatomy of the kidney itself, because it is
Yeah.
wildly complicated. And
I don't even know if I can go into that detailed anatomy anyways.
And like it is nuts. And we'll do an episode on kidney injury and things like that. 'Cause it's really important. But the kidney itself is important in how stones form, but less important in what happens once the stones form.
Mhm.
Yeah. And to that point, the kidneys themselves live in what we call your flank region. So this is your mid-back, kind of just at the bottom where your ribs would almost end, again, on both sides. And so when people start to develop kidney stones, they'll often refer as flank pain or kind of pain in that back. But then, as James was describing, that anatomy where the urine travels down from the kidney through the ureter into the bladder, sometimes that pain will radiate around the front. It might even be in your right lower quadrant, like we might see with appendicitis, for example. But it can be this kind of pain sometimes in the back, sometimes along the front or the lower part of the abdomen.
So what's a stone? What's a kidney stone then? We've talked about kind of the anatomy, but what's the actual stone we're talking about here?
Yeah, so similar if you were to leave a sugary drink out overnight and you start to see crystals form at the bottom, it's kind of how you can get stones in your kidney as well. It's filtering all these precipitates and minerals and things like that, and they can just start to build up. And as those small crystals start to form together or clump together, they can grow into larger stones, and these aren't like nice polished stones you're getting at the gem store. Like they're really uncomfortable, really sharp. And as they get bigger, they really hurt a lot.
There's got to be a story of someone who collected a kidney stone and made it into a wedding ring. We got to find that.
Ooh. Yeah. That'd be a decent sized stone. That's sure. That's fair.
Sounds
Yeah.
like
If any listeners that happened where you collected your
worst
stone,
way to propose.
yeah.
Hi, honey.
Yeah. But Josh, that is actually a good segue on collecting stones, because if you have a kidney stone and you pee through a sieve, for example, and you collect it, which I tend to recommend patients do, it's important because there's different types of stones you can get. And so you can actually test the stones to figure out what type of stone it is. And that can really help with what your management is going to be, your chance of it happening again, whether there's any preventative medications you could go on and stuff like that.
Yeah. Is it worth going through the types, just kind of big broad strokes?
Yeah, sounds good. So the most common one that we see is the calcium oxalate stones. These make up about 75% of all stones or so. And both calcium and oxalate are both normal parts of your diet and good for us to eat and play very important functions in our diet and our body. But when they start to get out of balance for the proportion of those, that's when they tend to stick together. And we'll talk about other kind of big risk factors and things, but things we would see would be if you're, dehydrated, high salt intake, high oxalate foods. These are things that can put you at higher risk for these types of stones.
Can you tell
the other
us
stones,
what they are? The high oxalate food?
High oxalate foods? Yeah. So these are things like spinach, beets, rhubarb, nuts, especially almonds and cashews, sweet potato.
Go back to rhubarb for a second.
Yeah.
Is that a regularly eaten food?
I've really only had it in pie version.
In a pie, yeah. Strawberry.
Yeah.
Okay.
Strawberry rhubarb. I don't know if I've ever had raw rhurbarb, but
I've seen them
covered
at
in
grocery
sugar,
stores.
I guess.
Yeah. They seem to be very highly acidic.
Okay. Cool.
Yeah. Are you questioning my decision for putting that in front of nuts?
Not. Now I am.
Me too. I have thoughts on that list, but you know what? I committed.
Yeah. I mean, I think it's not. I'm sure there are lots of people who enjoy rhubarb, so we don't want to discriminate against.
Yeah, I agree.
And
those who
I want to
enjoy
hear
rhubarb.
from you. Yeah, listeners who enjoy rhubarb, you tell us all the ways that you enjoy it. Besides
and
pie
I'm sure
version,
there's other parts of the world where it's probably a staple food.
Yeah.
Oh God.
Yeah.
I derailed us. I apologize, guys.
Very much so. All right. Okay. So those are the calcium oxalate stones.
Yeah.
The second most common are your uric acid stones. These are things we tend to see in patients that have those really high protein diet. So, keto dieters, bodybuilders. And we also see it common in people that have gout because they have a higher level of uric acid in the body. So those are the second type. The third are struvite stones. Now, these are a bit more rare. They tend to be more related to infections. So if there's an infection with the kidneys themselves, certain bacteria can change the acidity or change the pH of your urine and then actually may develop these kind of stones. And then lastly are the cysteine stones. And these are quite rare, tend to be related from genetic conditions where you leak cysteine, which is an amino acid, which tends to then clump up into stones as well. So it was calcium oxalate, which are the common ones, uric acid, which are from kind of protein and gout, struvite, which are infection driven, and cysteine from genetic conditions.
Yeah. And I think it's important to point out, just if you eat all this stuff and you have lots of rhubarb, for example, doesn't mean you're going to get kidney stones.
Yeah.
They are just contributors, and we'll talk a bit more how you get these things.
But if your diet is only rhubarb and steak, beware.
Also, I want to meet you because you are an interesting human being.
Fascinating person. Oh man.
But it's interesting though, because I remember in our obesity episodes, Jeff talked about a high protein diet as one of the diets that a lot of people use. So I think we're probably going to see more and more of these patients who have high protein diets who may have higher risk factor for uric acid stones. And some of the stats have shown that there's increase in prevalence of kidney stones in the United States and Canada over the last few decades. There are a lot of risk factors, but one of them definitely is diet.
And a lot of things in medicine, it's rarely one thing that causes it. So there's often other factors. Genetics often play a huge one in there. Other parts of your diet, medications you're on. So again, like we're going to go through a bit more, but it's rarely one thing that causes a medical issue.
Yeah. Not just high rhubarb intake.
Exactly.
Rhubarb's getting a lot of
diet. A lot of love for rhubarb.
Yeah, a lot of love.
Yeah.
Sponsored
Although I
by
might
rhubarb.
advise against a pure rhubarb diet, but yeah, otherwise I definitely wouldn't want to be taking away anyone's protein.
Yeah, I definitely agree. All right, so tell us, Brodie, because you see the patients who come in with this a lot. You know, certainly you've talked about it. This is excruciatingly painful. Why does it cause so much pain?
Yeah. So again, like these patients, often I can spot them as soon as they walk in and they're uncomfortable. Often they're vomiting. It's often a very quick kind of pain that comes on quite suddenly. Like they're sitting down having dinner, they're sleeping, and then all of a sudden there's this pain there and they can't get comfortable. And so, James, you're talking about the ureter, so the tube that connects the kidney down to the bladder. That's a very tiny muscular tube, right? It helps kind of get the urine down there. It might be the size of like a spaghetti noodle or so. But again, now all of a sudden inside that tube, you have these growing or very sharp-edged stones that are in there, and they get stuck along the way down. And then it's both a bit of a tearing. Sometimes there's some bleeding inside that goes along with it. But it's kind of like you're trying to push like a hard Lego block through a drinking straw. It's just extremely uncomfortable. Things aren't really blending well. Yeah. And that combination is just severe, sudden pain, vomiting, can't get comfortable. Like, it's pretty unrelenting.
I could attest, as somebody who operates in abdomen, has seen ureter in live action. It's a very tiny diameter, muscular. It moves, and, you can see if there's something that's, large stone stuck there, and then there's all this musculature working on it and trying to squeeze that, that could cause a lot of pain. So certainly I could kind of picture that, and I'm just getting it's cringe. I just feel like
my flanks
I empathize right for the patients who are experiencing this.
What's weird about these things is similar, James, in your world, people who get shoulder pain when they have abdominal issues, like liver issues, just because some of the nerves are essentially shared between those organs. People get nausea with kidney stones, and it's not just the pain itself, it's because there's actually shared nerves between the parts of the kidney and ureters that cause pain and the gut. And so it's just another interesting fact that doesn't change anything.
I like it. Everything is interconnected.
It is. It really is. Our bodies are fascinating.
I heard your muscular ureter, and all I thought of it was like the next action hero. I'm just like grinding it out. Just like, sign me up, ready for pain. He's gonna like take the world.
The ureter is the unsung hero of our human body. Carries so much liquid.
Every episode we have like fan fiction. We have live action comics just coming from every episode. We got to do this. We
just need fans.
Yeah.
Well, we got fiction and we got ChatGPT, so maybe we can throw these in and get some computer generated models.
Hey, I'm a fan.
Unless there's some artists that want to work with us.
That's right.
Oh man.
All right. So,
God.
okay, I think we could kind of picture why it hurts. Like it's a big stone and this muscular ureter that's a small diameter causes a lot of pain. But tell us how you would diagnose it. Like what symptoms do they experience?
So when we think about the type of pain that they're having, again, this is typically a sudden onset, severe pain that they have. But again, the stones can travel and they tend to get stuck in a couple of different places. So sometimes a stone will get stuck. You'll have a sudden amount of pain because there's the swelling that might be causing some bleeding in the ureter. And then it might get unstuck for a little bit. You actually get some relief. And then there may be a period of time where for 20 minutes, 30 minutes, an hour, a couple of hours, you don't have any pain. And then all of a sudden it might come back again. And typically that's where we see where the stone is getting stuck as it's moving on its way down. Sometimes we'll describe it as renal colic because it's this kind of colicky, episodic, severe pain that they're having as well. We might see an elevated heart rate. Sometimes the blood pressure goes a little bit up with that as well because they're in there a lot of pain. Sometimes there's a low-grade fever, although that usually makes me more worried about an infection on top of it. But really the diagnosis is made through some tests. And really, there's 4 main tests that we look at. We look at your urine, so a urinalysis. And in here, typically, we would see signs of blood or bleeding. But we also want to look for any concurrent infection. We'll talk about why that's important. So we look at red blood cells, which are signs of kind of bleeding within the urinary tract. But we also look at things like white blood cells, which are more infection or inflammatory cells. And then something called nitrites, which are kind of breakdown byproducts of bacteria. We'll often do some routine or kind of relatively basic blood tests. The one I think we're most interested in here is something called your creatinine. We've kind of talked about this before, but this is really an assessment for kidney function and how well your kidneys are filtering out proteins in your body. So why this is important is if you have a big stone that's blocking your kidneys or stones on both sides of your kidneys, for example, you can actually get an elevation in your creatinine, which would be signs of kidney injury, which again, just make us want to watch you a little bit more closer or maybe bring you into the hospital, depending on how abnormal those are. But then really to kind of cinch the diagnosis, we're really looking at imaging. And for that, we're often doing a CT scan or an ultrasound. And there's pros and cons to each of them. I'd say a CT scan is what I tend to go for if it's the first time someone is coming in with possible kidney stones. And the reason for that is it's a more accurate test. It helps me look and rule out other causes of this pain besides kidney stones. So things like appendicitis, diverticulitis, or even things like cancer. Again, we have these first-time presentations. It can help rule out these other things. And then if the other imaging test then would be an ultrasound. So ultrasounds are nice because they don't have any radiation, but they're not as accurate in being able to see all of the stones, but they're really good then for people that have recurrent stones, people that are pregnant, young people, that sort of thing.
Yeah. And I think if we take a step back, even before they emerge, family doctors are going to see a lot of this. They may just order a straight up x-ray to start. X-rays are fine. They don't see some types of stone depending on what the stones are made of. So it's a good start. But if someone has classic pain for that and the x-ray is normal, it doesn't rule out a kidney stone.
Yeah. Brodie, since I don't think we've covered this before, urinalysis or urine tests, when you ask someone to do urine tests, can you tell us like what's important? Like in terms of like, is it midstream or, discard the first little bit or, there are little things that I remember I was taught in med school, but I forgot. Maybe you could remind us. And I think the listeners will find that interesting and useful.
Yeah.
I usually think of it with the exception of our chlamydia and gonorrhea episode where you want that early stream. But again, that's a specific urine test, not my standard urine analysis. Most of the time I'd want a quote unquote midstream urine. So I'd want you to kind of, as you're peeing, now put the cup under, collect it, now take it away, kind of finish
like
it.
After like a second or two kind of
thing. Exactly. Yeah. Kind of depends on how much pee you got in there, but I'm not really interested in like the first little bit that comes out. I don't want you to not have enough, so I don't want like the end dribbles. I want kind of somewhere in between.
So you talked about all the workups that you do, but definitive diagnosis is really through imaging, right? Is that fair to say?
Correct. Yeah. And again, it's a CT scan, I'd say 99% of the time is able to show us a stone. An ultrasound can the majority of the time as well, or otherwise we see complications of a stone, like an enlarged kidney. And then again, some x-rays. But really, especially their first time, really should be confirmed on imaging.
Yeah. Another thing that I want to ask you on the CT scan part is not all kidney stones on imaging are culprits for your symptoms, right? So if there's like something really small, for example, so are there different characteristics on the CT scan that you look for that will say, okay, this stone is likely to cause the symptoms?
Yeah, that's a great point, James. Really, it brings me back to our gallstone episode too, right?
Mm-hmm.
Again, if you have stones in the gallbladder, but they're not impacted, very similar with the kidney. So some people have kidney stones all the time, but they don't cause any pain because they're really within the main part of the kidney, what we call the renal calyx, and they're not stuck. They're just kind of there floating around. They might dissolve, they might not, but they kind of hang out there. It's often once they start to travel into the ureter where they get stuck, that's where we then to see where they're causing pain and people start to have symptoms. So findings we would see that on imaging that would be attributed with that then would be things like swelling of the kidney, or might say the term hydronephrosis. Sometimes you can get hydroureter, which is swelling of the ureter itself. There might be stranding, which kind of internal swelling they can see on the CT scan, for example. Those would be the things that we would see sometimes on imaging.
So there's some evidence of obstruction, right?
Yeah, exactly. Yeah.
All right. So we found the kidney stone and we think that it's causing your pain. So how do you treat it, Bros?
Yeah. The other benefit to imaging is we get a sense of the size of the stone. And the size won't necessarily directly impact what we're going to do for you today in the emergency department, but it gives us an idea for what your likelihood of the types of interventions or type of management that you're going to need for it. So again, we're talking about kidney stones. We talk about very, very small size. So we talk in the sense of millimeters. And maybe just overall, if it's any reassurance to people that are having or may have a kidney stone, about 80% of kidney stones as a whole pass on their own, so they don't need to go on to need any sort of advanced things. When we think about kidney stones, 4 millimeters and below is really this is quite safe zone. So if your stone is less than 4 millimeters, over 90% should pass naturally, whatever that means, or pass on their own. I don't know.
Without intervention.
I guess stones are natural, but I don't know. Anyway, still 90% of the time they'll pass on their own if they're under 4 millimeters. The timing for that though is, most people take 2 to 4 weeks for that to happen. So it's not always like it's going to be out there by the next day. The next range we see are kind of those medium-sized stones, and those are kind of 4 to 6 millimeters, and those have a slightly lower chance of passing on their own, about 60%. And we see they do tend to stick around a bit longer. So on average, people take closer to kind of 45 days for those stones to go. And then really once we're over 6 millimeters, then your chance of it going on its own drastically goes down, like less than 20%. And those are the ones that we're really referring for urology, for medical intervention. And we'll talk about what that'll be in a second there.
Yeah,
I don't know if it's helpful or not, but
no, it is. And I think it's reassurance for people that if you have kidney stones, the majority are small. Of the small ones, I think there's a decent percentage that you won't even know you have them when you pass them. Like many do cause pain, but I don't know what the percentage is, but you may pass it. Never know.
Yeah, definitely. We've definitely had that before where they might have like a little bit of blood in the urine for a day or two. It clears up and that's kind of it. And they may not have a ton of pain. That definitely can happen. Yeah.
And actually
Purely
just
with
looking it up,
smaller
20 up to 20% from what I'm reading here can pass without you even knowing you have them.
So I can talk about maybe what we tend to do in the emerge when you come in. And really the first thing, again, these patients are super uncomfortable. So the first thing we're doing is really just pain management, right? We'll often put an IV in these patients. We're going to be giving them pain medications. Non-steroidal anti-inflammatory drugs, or NSAIDs, tend to be the most effective pain medication for kidney stones or renal colic. So this would be like an IV version of Advil or ibuprofen. So something called Toradol is one that we tend to reach for pretty quickly. Or if they're able to tolerate swallowing pills, we might give them Tylenol and Advil. That's usually the first thing, is some IV fluids, anti-inflammatories. And sometimes it's really severe. We need to go on and give them narcotics like morphine or hydromorphone to get them settled and comfortable.
Just for our fan fiction, I tell patients Toradol is like super Advil.
Yeah, definitely. Yeah.
Yeah.
I know. I never want to say like just Advil because it works so much better.
Oh,
it's so
It's
great.
pretty fast. Yeah, right away.
And very fast. And then for most people, because again, their stone is most likely going to be this kind of small to medium size, I'm going to send them home. So I'm going to send them home with pain medication. So, first line again is anti-inflammatories. So again, like in ibuprofen or Advil or naproxen. And I tell people to take the pain medications regularly, right? We know that like all medications, they wear off after a certain period of time. And if I know that stone is going to be there for like 2 or 4 weeks, then I really want you comfortable, because otherwise the pain's going to get worse and you're going to have to come back to hospital. So I'm discharging these patients with these non-steroidal anti-inflammatory drugs and telling them to take it every 12 hours or every 8 hours, depending on what it is, just so that they've got something on board to keep them comfortable. And then often I will prescribe, I guess, like a morphine or hydromorphone, something stronger, so that if the other medications aren't working, they don't have to come back to the emerge necessarily if it's just that.
For a breakthrough.
Yeah.
breakthrough. And just to be clear, like these are the patients that are coming in with clear kidney stone related pain, not the ones that you just see a kidney stone when you're looking for something else.
Yes, exactly. Yeah. These are people that have coming in. We've done imaging. I'm convinced it's a kidney stone, and the kidney stones is the cause for their pain. That's what I'm sending them home for. Yeah. And then the other things that we tend to do as well is we encourage hydration. Now, we'll talk about this maybe later. I'm not saying like you're going to go home and chug 4 liters all at once as everyone takes a drink. But,
drink break.
make sure that you're at least staying well hydrated. Because again, a common cause of stones is dehydration. And then there's medications we can do for medical expulsion therapy. So these are medications like tamsulosin or Flomax. Interestingly, we commonly prescribe these for men with prostate issues in the same way that they help with blood flow and peeing by dilating the ureter when people that have enlarged prostate. Similar thing for helping a stone pass. Just kind of helps give you a little bit more wiggle room, a couple more millimeters in your spaghetti tube to let those stones go and pass.
Toit.
Well played.
His joint in there. It's too muscular. He's got to stop working out.
Or she.
Or he or she. Yep. Talk about the muscles. And then lastly, it always sounds weird, but I do recommend people pee through a sieve to try to catch the stone. And again, I don't know, maybe you've got it home. It's always an awkward conversation. Where do you get one?
Yeah.
James.
Can you recommend?
What kind of sieve?
Is it the metal one that you have at home in your kitchen?
Yeah, because I mean, you need something like that because it's got to be small. So yeah, like your metal pasta strainer, because you need something that's going to get something.
Coffee filter.
Coffee filter. Yeah, but that'll probably fill up.
I think it's going to be too
much.
slow to filter out.
Yeah, you'll just pee on
I got
yourself.
some big coffee filters. Yeah, good call. Yeah.
So yeah, honestly,
so there's
like
no
that's
medical sieve. There's nothing that you wear.
If there is,
I'm looking this up right now.
If there is, I apologize to everyone who I've been telling to pee through their pasta strainer for the last 15 years.
And then they have to use it again afterwards for cooking.
Guys, no, hold on. I just looked this up. Comfort Access Stone Collector, non-sterile calculi strainer. They're out there. This is Amazon and not endorsed by any means. There's one. Hold on. There's one called the Pocket Strainer.
I'm sure that it's very subtle and convenient.
Portable.
Do they mention any other uses besides catching a kidney
I'm not
stone?
going to read. I don't want to go down that. Oh no, they come in 3 packs, by the way. Sorry, continue.
I wonder about if you're taking it to go, is the plan to then put it back in your pocket after?
Yeah, exactly.
Anyways.
Well, that's why it comes in a 3-pack. you throw that out.
They're expendable.
Yeah.
Guys, I love this podcast. The things we uncover.
I'm glad that I know now. I'm a better person now that I know about this than before. So thank you, Brodie.
Yeah.
You're welcome, guys. Yeah.
All right.
So Broads, when will you do more in the emerge? Like what's going to kind of tip you off to something more is going on? And when are you going to refer to urology? Because I think those are two important things.
Yeah. So I'd say where the pathway changes in the emerge is if there's some red flags. So these are people that have fever or I'm worried about a concurrent infection in the kidney. That really is like one of the few urologic emergencies. Urologists may disagree. Yes, but, fever with an infected kidney stone, definitely an emergency. Yeah. It's also an emergency if that's your only kidney. So these might be patients that have a transplant, or if they're born with like a single solitary kidney, or if they already have really bad kidney function. So again, looking at their creatinine and their blood work, if it's quite elevated, again, I'm worried about that. And then lastly, if like people really can't keep anything down. If I'm trying to send you home on oral pain medications and you're just vomiting the whole time, I probably can't send you home. So that's where things change a little bit for what that initial management would be, where I would normally just send you home. Those are patients that are going to stay. Typically, unless they have those red flags, I'm still sending you home. But if you have a larger stone, I just know there's a higher likelihood it's going to need something. It still might pass on its own. So then I'm making the referral to urology. And again, usually the urologist will see you in a couple of days or a week or two, because again, sometimes these stones pass anyway. So it allows them to kind of give you the opportunity to pass this on your own before kind of exposing you to the risks of a medical procedure or intervention that you may not need if your body's able to pass the stone on its own.
Yeah. And the urologist may very well do nothing different either, but they may follow you and re-image you and eventually discharge or have to do something more invasive, which we'll get into.
Yeah. And if you do pass a stone, if you bring it in, they can analyze it. But really, there's three main buckets or interventions for when the stones are bigger, they're not passing, there are those red flags. And these are shockwave lithotripsy. So this is where they're using kind of like sound waves or ultrasound to kind of break up the stone. They can do something called a uteroscopy, where they actually kind of go up, pass a bladder into the ureter. Sometimes they can kind of laser things out. It's very like Star Wars, like Death Star.
Yeah.
And then in some cases, they actually put stents in. You're kind of going on the inside, stenting open that ureter so it's big enough that the stone can pass. But then the stent has to be retrieved or taken out at some point in time. So again, always best if you don't need those things and it's able to give yourself a bit of time to allow things to pass. But those are the three big things that you'd be looking for that the urologist may do if it's not passing or there's some of those red flags.
Yeah, exactly. That's actually a really good segue to the next important topic. Let's say you have one of these stones and they're removed or they're broken up. You're still at risk of getting them again. So Brodie, maybe kind of go through what causes kidney stones and how to prevent them, because I think those two things are directly related.
Yeah. At a high level, really people develop kidney stones where there's an imbalance between the things that promote crystals and the things that prevent crystals in your urine. And there's a handful of culprits that we'll talk about. But by and far, like the number one reason is patients are dehydrated. They're just not drinking enough water. So again, if you think your urine is concentrated, you should have more of like a pale yellow as opposed to kind of an apple juice type color. Try to be cognizant, drink more fluid.
And again, depends on the type of stone too. Hydration works better for some stones than others, but that is a core tenet to many parts of medicine. Stay hydrated.
Mm-hmm.
Second thing are high salt diets. Yes, salt definitely makes food taste a lot better. It does make your kidneys work a lot harder.
Yeah.
And it's not just the sodium itself. Again, kidneys are very complicated. When you eat a lot of sodium, your kidneys, as they're managing that sodium, they also end up dumping calcium into your urine. So you can think of it as like the more sodium you eat, the more calcium you're putting into your urine. And as we talked about, the more calcium in the urine, the more chances of you getting these stones, especially those calcium oxalate stones. And so the third thing, again, along the line, would be really high oxalate foods. And again, looking at the imbalance for calcium. So again,
can you tell me which food has high oxalate?
No, nobody say the word. Nobody say the word. We're done.
I think it starts with R. It ends with barb.
Yeah. But the one thing that's interesting, I won't run that list again, but the one thing that's interesting is then some people think, a low calcium diet will actually be better. But it's actually not the case. Calcium on itself isn't bad. Oxalate on itself isn't bad. It's the mismatch between the two. So especially if you're having more oxalate, if you don't have enough calcium, if you're restricting your calcium, then you get less calcium absorbed, so it goes into the kidneys, and then it actually connects with the calcium in your kidneys and then gets stones. So,
and that used to be the recommendation, like years ago, say low calcium diet, and then all this evidence came out and said, I think that's actually worsening things.
Are bad.
Yeah. Oops.
It's okay. I think we talked about that before. Most of the things that we learned were wrong. And I'm sure most of the things we're talking about today will eventually be disproven as well.
Yeah.
But it's okay. There's no way this podcast will live forever and people will say, these guys were so wrong.
The sieve will forever outlast us.
One true lasting medical intervention.
The pocket sieve is the best investment of all time. Do it.
God. Fourth thing that we see for risk factors are specifically high animal protein intake. So your red meats, poultry, fish. And what we see is the protein makes the urine more acidic, and that's increased acidic environment, which helps kind of promote stone formation. Mm-hmm. And then there's kind of the more rare things. So we talked about somebody's family or genetics. So if you happen to have someone in your family that had a kidney stone, hate to break it to you, but you probably have a higher risk for kidney stones as well. And then gut issues as well. So patients that have difficulty absorbing things in the body. So these be people with inflammatory bowel disease like Crohn's disease or ulcerative colitis. They have chronic diarrhea. Or James, with your bariatric surgery patients.
Your time to shine.
Again, you have more difficulty absorbing that oxalate, which means more of it ends up in the kidneys, which again, as we know now, is a recipe for kidney stones.
Mm-hmm. Not all bariatric surgery, but that's why it's very important to be compliant with micronutrient guidelines that we have for our patients.
Love it. And then I think just to add on, and we won't go into detail, there are certain medications that can increase the risk of certain types of stones, but we would never not put a person on a medication just because of the stone risk if you need the medication. So won't get into those in details, but there are some. I think like we were going to talk about prevention and stuff, but I think it kind of goes along the lines of what you just talked about, Brodie.
Yeah.
Prevention is kind of avoiding those
opposite.
things. The opposite of what you just said.
Low rhubarb diet.
Low rhubarb diet, low salt diet. Stay
You just ordered a
hydrated.
Costco amount of rhubarb. What am I going to do with it?
All right, so
Yeah.
maybe we should
All right.
now do our favorite segment.
Yeah. I prepared some myths to bust for you guys, if that's
Uh-huh.
okay.
Yeah, absolutely.
Also, I'd say like it's a question. I know it's okay because
Confirm or bust. Let's not be
Yeah.
biased here.
Yeah.
Confirm or
Yeah.
bust.
yeah. Okay. All right. So first myth, we're gonna bust it there. Do energy drinks cause kidney stones? No.
Is this-
not directly? Yeah. This is a thing. Yeah.
This is a thing.
This is a thing. Commonly asked on Google. Yeah. You could also
Cool.
swap energy drinks for like soda or pop or carbonated drinks, but
Okay.
the answer for all of those is no, not directly.
Oh,
But-
thank you. I love Dr. Pepper, so I would have been devastated.
The OG doctor. Yeah.
Yeah, exactly.
So the energy drinks don't cause kidney stones, but they do give you wings, though, right?
Yeah, they do. Yeah, it's, Red Bull is still
that, is
fun.
that is a sponsorship plug right there. That is awesome.
We give you wings, not stones.
Right. So not directly, Brodie. But
but
like you
things
said,
that are-
if they have, go
Yeah,
ahead.
high in sugar, high in sodium. They're highly acidic, and put you at risk for dehydration. But good news for
That's a
those
good-
that are
that's a
just
good
like
one, yeah.
drinking normal, like plain sparkling water. You're
Yeah.
okay
Mhm.
because without those additives,
Mhm.
it's the carbonation itself doesn't do it. It's really the
Uh-huh.
acidity, often the kind of phosphoric acid and sugars and stuff they're adding. So plain sparkling water on
Recall.
your own should still be
if
okay.
you didn't say that, big sparkling water would have come after us because it
I
is
know.
like the most absolutely popular thing right now. We would have been in so much trouble.
Yeah.
All right.
Big water. Is that what we call them? Instead of big pharma, big water would come after us.
Big
water.
water. Yeah.
The water
Big
mafia.
food, big water, big farm.
Yeah.
I think our next one I'll just take because I already said it. And
Yeah.
I just I feel like I have to show I have some knowledge, but I don't about kidney stones. We already talked about, can you pass stones without pain? Yeah, about 20% of people probably will for the smaller stones, but many people unfortunately will have that kind of pain that Brodie talked
Yeah.
about.
I think, Brodie, the next one is really interesting. The cranberry juice. It always pops up like for a variety of reasons. Tell us, Brodie, whether cranberry juice is helpful to get rid of kidney stones.
Yeah, so no evidence for it helping with kidney stones, but there is decent evidence for it for preventing or treating urinary tract infections or UTIs. So if you're drinking it for those reasons, continue. If you enjoy cranberry juice, continue, but it's not going to help you with your stone. The next one I
Have fun,
see
Brodie.
often is do kidney stones dissolve? So no, most don't dissolve, with the exception of some of the uric acid stones can be given medications to dissolve them. Pretty much everything else, though, needs to either pass or be broken up in urology. So if the stone's in there, it's probably got to come out. Or it might just live in there forever and you're totally fine, which is another subset of people.
And then I'll just finish off the myth busting segment with I can flush out a stone by drinking a ton of water. If they're stuck, often they're stuck. And you may need a bit more intervention than water.
Yeah. There's not really like a plunger equivalent for your urinary system. Like
Uh-huh.
once it's plugged. You can't really dislodge it by drinking much more. It's kind
I
of the
was
way think
about
about
to
it.
Google kidney stone plunger, but I don't want to go down that route because
I'm
I don't know what
kind
I'll
of
find,
interested.
nope.
Your,
I don't want any algorithms taking over
Yeah.
once I write that
your
in.
shopping suggestions will be very interesting.
Yeah.
I already looked up kidney stone sieve. I am stopping there.
Oh man.
Oh, God.
All right,
All
boys.
right,
This was
so
this was
I thought
fun.
this was
Should
really
we bring it home? Close it up.
Maybe I'll start by stating the obvious. We should avoid high rhubarb diet to prevent kidney stones.
Off script.
No, my take-home message here is hydration. Really, just keeping yourself hydrated, making sure that your urine is usually clear, and that's the simplest way to prevent kidney stones.
Yeah. I think number 2 is diet does matter. And I'm not going to go into specific diet recommendations because it depends on the stones you have or depends on the stones you may not know you have. So diet matters. Listen to your doctor when they talk to you about that.
And I'll wrap up with the red flags. So fever, vomiting, can't keep anything down, Or if you've only got one kidney, again, probably stay in the hospital. Need to get treatment right away. Thanks, guys.
Awesome. So I
This
think,
was fun.
guys, to finish off, we should all take a big swig of water and sign off with that.
Right.
Cheers
Cheers to our kidney.
Cheers.
to the kidneys.
Take it easy, guys.
See you guys.